UK, and I have been asked to talk to you today about seizures. And my my perspective on seizures is how to manage seizures in the acute setting, in the emergency setting. So this is not a talk from someone who is a neurologist who deals with difficult seizures in a clinic on a long-term basis. I'm talking about the more emergency side of things. For example, this scenario. So imagine you're working in a hospital or emergency clinic and you get a call or someone comes and gives you a message and says there's a 19-year-old female with known epilepsy and she has been seizing continuously for 40 minutes without recovery. And she's been getting boluses of IV lorazepam, but still she fits and seizes. What do you think? What is the diagnosis in that particular scenario? And by the way, please do write stuff in the chat box. I've got it open here so I can see. If you have a question as we go through, or if you have a point to make, or if you just want to say hello or say something clever, then please do pop something in the chat box. But has anyone got any thoughts? What do you think about this person here who has been fitting continuously for 40 minutes? This 19-year-old person. So Kathleen says status epilepticus. One of our medical emergencies, quite an exciting medical emergency as a doctor if you're into that sort of thing, but you're right, status epilepticus. So this is something that needs treating, obviously. Status epilepticus is actually defined as a seizure lasting longer than 5 minutes, not a long time. Maybe you remember if you've been qualified for a while, it used to be 20 minutes, but now it's 5 minutes. So no recovery, or they're having back-to-back seizures, but no recovery in between for 5 minutes, and that's status epilepticus. And status epilepticus is a medical emergency. Your patient is in danger. Any other thoughts? Maybe not, but could it be anything else? Or maybe I'm jumping the gun here. Or maybe, yeah, anything else? Just maybe just at the back of your mind, what else could be going on here with this patient? If not, don't worry, we shall come to it. Okay, let's have a think. So, why status epilepticus is so dangerous for patients? When the brain is fitting, having this disorganized, chaotic electrical activity, the cerebral metabolic rate increases by a dramatic amount, 300 to 400%. The brain very quickly burns through any available glucose for respiration. And cerebral hypoglycemia and cerebral ketosis develops very, very quickly. This is coupled with hypoxia, because a patient who's in status epilepticus is usually not breathing in an ordered fashion and moving oxygen into their bloodstream and to perfuse their organs. Very commonly, people with status epilepticus occlude their airway because they might have landed in a funny position, or their GCS might be so suppressed that they lose any tension in their posterior pharynx and occlude their own airway, or maybe they vomit and they aspirate. But this cerebral ketosis, this cerebral hypoglycemia, this cerebral hypoxia results very quickly in cerebral necrosis, and they start developing ischemic or infarcted brain tissue. People who have poorly controlled epilepsy often develop bad scarring on the brain, which is called sclerosis, temporal mesial sclerosis, which in itself is a risk factor for more seizures. So the cerebral effects of uncontrolled seizures are actually pretty catastrophic. And if they don't develop those, they could still lose an airway and die pretty quickly of suffocation. Other complications, someone who's having a generalized tonic-clonic seizure or a tonic seizure very quickly puts up their CK, they start getting muscle breakdown, which of course causes AKI. And the high lactate, I mean, what's the highest lactate you've seen on someone who's just had a fit? They can be pretty astonishing. I've seen ABG on people who've just had a seizure and the lactate is 19, 20. And untreated, this can lead to multi-organ failure. So status epilepticus is a very dangerous situation to be in. How are you going to treat this patient? Where you work or just in your own clinical practice, what do you prefer? What's your first line treatment for status? I'm interested to know, and then I can tell you what our guidelines are. Does anyone mind sharing in the chat box what they use. What drug, what dose, and what route? Okay, no one is sure. Here we go. So benzo, diazepam IV from Anil. Yes, that's a good first line one. Any other options? Yep, benzodiazepine, very good idea. So benzos are indeed first line. And where you work, maybe, and what's available to you in your particular situation when you encounter this patient really dictates on what you give. Intravenous benzodiazepines is absolutely the first line. And maybe you give diazepam. Where I work, we give lorazepam because it has a good rapid onset of action and is not too long acting. The half-life is much shorter than the diazepam. So they tend to be less likely to have that prolonged sedation after you've given it. And we give between 2 to 4 milligrams, well, 2 milligrams really of lorazepam, maybe half a dose, so 1 milligram in very older adults. And then as a second line, if it doesn't work within a few minutes, we give another dose. So you may be giving two times 2 milligrams of loraz, which is 4. I've seen people give diazepam. I've seen people give midazolam. Fair enough. Very rapid onset and offset of midazolam. And that's if you've got IV access. If you don't have IV access, you have to make some decisions. People who have well-known epilepsy often have family members who are trained to leap into action and deliver parenteral benzos if someone has a fit at home. And that might be buccal, so putting a little tablet in there between the cheek and the gum, or rectal, especially in pediatric patients. In hospital, if we don't have IV access, we tend not to use buccal and rectal methods of administration. Buccal because I always feel it's a bit risky putting your fingers inside the mouth of someone who's having a generalized tonic-clonic seizure, because of course they can clench, they can bite, they can cause you injury. And also there's just a risk if you're not trained or you don't get it quite right of impairing their airway or eliciting a gag reflex if you go too far down, making them vomit. And also giving rectal, you can do if you think you can have easy access, but if the patient's fully dressed or maybe has a high BMI, it's difficult to roll them over. So in hospital patients or in the A&E department, our next strategy is to give IM, and it's exactly the same dose, intramuscular. So injected into their deltoid or into the upper outer quadrant of the gluteus muscle. And it's the same dose, so 2 milligrams of lorazepam. The onset of IM benzos is only a minute slower than IV, so you still get pretty good access. So that's what we're going to give as a first-line treatment. And I've mentioned all of that. And I've said here up to 2 doses. I sometimes come to clinical situations where a patient has had 2 milligrams of loraz, then another 2, then another 2, then another 2, and it's 30 minutes in and they're still fitting. And I would advise you not to do that. This giving excessive benzodiazepines, that's more than 2 doses, actually has a negative effect on your patient. If you give 3 doses or more, you've increased the odds of them needing to be ventilated in intensive care, of having severe respiratory depression, which can have a increased mortality and morbidity. So 2 benzos max, then move on to your second line. What is your second line treatment for status epilepticus? Anyone? Phenytoin from Dr. Al-Husseini. Yes, it's a really good option. Phenytoin as well from... Anyone else give anything different to phenytoin? Okay, so phenytoin is a very good second line, but I agree with you. 2 doses of benzos, then we move straight on to our anti-epileptic drugs. We don't keep giving doses of benzodiazepines. Loading with IV phenytoin is in all the guidelines that you will see. Loading with phenytoin has, in the UK, fallen out of favour a little bit because we have other drugs available, and I completely appreciate they're not always available to absolutely everybody all around the world. Phenytoin is something that's weight-based. So it's impossible to get a weight on someone in status epilepticus. You have to sort of look at them and make a judgment call. But in an average 70, 80 kilo person, then 1.5 grams should be okay to give. And we've got somebody giving carbamazepine or sodium valproate. I've loaded with sodium valproate before, certainly. I've never loaded with carbamazepine before in status epilepticus, so I'm intrigued by that one. But phenytoin has side effects. It can cause arrhythmias, tachyarrhythmias. So you need a cardiac monitor. Long-term phenytoin is very rarely used now in the UK because of the side effects such as cerebellar syndromes, the gingival hyperplasia, hypertension, and it had been supplanted by another drug, which you probably have heard of and maybe is available to you or not, but it's called levetiracetam, otherwise known as Keppra, because that's easier to say and to spell. So what does the evidence say? There isn't clear evidence to say that sodium valproate or levetiracetam is inferior to phenytoin, and it might be superior. We know that loading someone with sodium valproate is just as good as phenytoin and has fewer side effects. And we know that levetiracetam or Keppra probably is as effective as phenytoin with fewer side effects as well. The main studies for these are called the Eclipse trial, where they found that loading with Keppra, loading levetiracetam, is probably just as fast as loading with phenytoin. We tend to maintain people who go on long-term anti-epileptic drugs on levetiracetam or valproate or sometimes carbamazepine, but it's very rare that people get maintained on phenytoin. So we can start by loading someone on phenytoin, but be aware that when that patient recovers from status epilepticus, they'll probably be maintained on a different drug, which requires a period of cross-weaning. One drug goes down as the other drug is introduced, and that can expose the patient to the increased risk of seizures, breakthrough seizures, while they're going from one drug to another. So in the interest in getting them on the right drug first time, there's a good argument for loading them on valproate or with Keppra. The newer anti-epileptic drugs, Keppra, valproate, are better tolerated, fewer centrally depressive effects, don't interact with as many drugs. So you remember phenytoin interacts with many other drugs via enzyme adjustment on the P450 chromosome. Yeah, going against them is that they're expensive. So phenytoin is quite a cheap drug. Here I've got down valproate is about £57. It's not on there, but phenytoin is about £25, and levetiracetam is £114. So this is something to think about as well in your healthcare systems, why you might not have this available to you. So loading with phenytoin is a good option. If you want to load with levetiracetam, you can reach for levetiracetam. The dose is about 40 milligrams per kilogram with an absolute upper limit of 4.5 grams. So we tend to do that mostly in the UK now. Now, if you haven't managed to get control of the seizures with 2 doses of benzos or by loading an antiepileptic, the third line is paralyzing the patient and sending them to intensive care for a general anesthetic, really, and an intubation. So slightly outside of what we're talking about here. Very, very rare that status gets to that stage, though, where they fail both benzos and antiepileptic medication. I've only seen it once in my career. I wonder if any of you ever heard or seen non-convulsive status epilepticus. I've seen it quite a few times, and since I've been more aware of its existence, I see it a bit more often now because I'm more sensitized to the diagnosis. So this is someone who is in status epilepticus, but they're not moving and they're not having a generalized tonic-clonic seizure. It's really interesting. So they might be in complex partial status, or they might be in a generalized status, which is an absent seizure status, which you see more commonly in pediatrics. And they're really difficult to diagnose because they look very much like a hypoactive delirium. A US study back in 2013 suggested that 3% of patients coming to A&E, if you did EEGs on everybody who comes into A&E with altered mental status, 3% of them are actually fitting. They're having seizures, even though you can't see any abnormal movements on cursory examination. And a French study in 2010 found that 16% of elderly patients over the age of 60, who had a delirium of unknown origin, were in fact having seizures. So seizures in people who are sitting still and not really interacting with you, non-convulsive status epilepticus. We know that there are some predisposing factors to developing this strange disease, having concurrent meningitis or CNS infection, any kind of structural abnormality of a brain or a scar. So a previous stroke, a brain tumor that might interrupt normal flow of electricity through the brain. A known diagnosis of epilepsy is something that should raise your suspicion if they suddenly go very quiet and they're having this hyperactive delirium. Or people on long-term benzodiazepines who suddenly stop them. Really, it's benzodiazepine withdrawal, basically. And there was an interesting study saying, how can we detect non-convulsive status epilepticus just by examining our patient? Because we don't all have EEGs at our disposal to immediately put on the patient and detect epileptic activity. So it came up with a few factors that you can look for. It says, look at the past medical history. Are there any recent risk factors, i.e., did they suddenly stop their benzodiazepines, or do they have a CNS infection? They said, do they have any remote risk factors, i.e., a pre-existing structural brain abnormality? Was there any tonic-clonic activity which preceded this presentation? Do they have a history of epilepsy? Any ocular movement abnormalities, and this would be either just a very tiny fine flickering of the eyes or roving eye motions like that, not fixing on anything, or subtle motor activity. And subtle motor activity is usually either small fasciculations of the muscle around the eye or in the cheek or around the lip, or fine little fasciculations or jumps in the small muscles of the hands. So always look at the eyes and the hands as well. And it found that actually one of these signs on their own was not very sensitive or specific for diagnosing clinically non-convulsive status epilepticus. But they found that if they had a predisposing factor in their past medical history and those subtle ocular movement abnormalities, it had 100% sensitivity for picking up someone who were having subclinical or non-clinical seizures in front of you, which I thought was really interesting. So my tip here is that always look at your hypoactive delirious patient who you've got a suspicion they might be having non-convulsive seizures. Look at their eyes, look at their hands, and then look at their past medical history. Do they have any risk factors for this? Treating non-convulsive status epilepticus exactly the same as convulsive epilepticus. It doesn't look very dramatic. They're sitting there quietly, but remember, they still have that 300-400% increase in cerebral activity. They're still at risk of brain damage, neurological damage. Here's an interesting story I just wanted to tell you about. This is when I first got interested in non-convulsive status. It was a long time ago now, but a 64-year-old man came into my hospital with hyponatremia, 124 it was, which was due to SIADH, syndrome inappropriate ADH secretion. And he had a hyperactive delirium. He was very vague and not really following a conversation, was very distractible and quite withdrawn. All his inflammatory markers, so his CRP white cells, were normal. And on day 1, we did a CT scan of his head and it was normal. On day 2 of his admission, we did an MRI scan of his head. It was normal. His sodium normalized, but still he got more and more withdrawn and quiet and delirious. On day 3, we decided to do an LP because we were thinking, is this encephalitis, viral encephalitis? And the LP, the CSF analysis was normal. Day 4, he deteriorated suddenly. His GCS dropped down to 8 and he stopped responding and he was sitting very, very still. We managed to get an EEG, an electroencephalogram, on the ward, and the neurophysiologist came, put the dots on the head, did the EEG with the patient in bed, and they found on the EEG widespread epileptic activity in keeping with status epilepticus. And whilst they were doing the EEG, they administered 0.5 milligrams of intravenous midazolam, at which point the patient opened his eyes, sat up, and started talking because they had abolished the seizure. And that really blew me away. I'd never seen or heard of anything like this. And that's why I got interested in non-convulsive status. And I started looking for it a bit more. And made me ask my question, should we be doing EEGs more often? Should we be doing EEGs in all patients who have an unexplained non-resolving delirium? And if so, how long is non-resolving? Do we wait for day 4 in everybody? And of course, EEGs are not widely available everywhere. You have to be working in a pretty large hospital to have that test. I found this guideline in the Postgraduate Medical Journal. And it was a suggested practical approach to the diagnosis of non-convulsive status epilepticus in confused older people. And they suggested this pathway. Are there any easily recognized cause of delirium in this patient? If yes, fine. You don't have to go down the pathway, treat or correct the cause. If not, are there any features that we have found to be associated with non-convulsive status epilepticus in older people, i.e. female, history of epilepsy, previous neurological injury or structural problem, any recent benzodiazepine withdrawal, or any of those subtle clinical signs? So myoclonus, any speech disturbance, any automatisms, which you see in people with complex partial seizures, lip smacking, plucking at clothes, those subtle ocular signs, those subtle little fasciculations in the hand or in the face. If yes, are there any underlying reversible causes for the seizures, such as stopping drugs, stopping alcohol, or a metabolic disturbance, such as hyponatremia, for example? And if so, correct. Do you have an EEG? If yes, do an EEG and make your diagnosis. If you don't have access to EEGs, consider a therapeutic trial of anti-epileptic medication and then looking at the response. So almost as a diagnostic test, load your patient on phenytoin, load your patient on levetiracetam or valproate, and then watch. Maybe they'll get better, but maybe they won't get better, but maybe they will, like in my patient. And I actually have done that a couple of times. So I've worked in some hospitals where I simply don't have access to EEGs, but I've met patients, sometimes in the middle of the night, who I think might be having non-convulsive status. And as an experiment, I've loaded them on intravenous levetiracetam and watched them. And I have to say, in about half of the times I'm wrong, nothing changes, but no harm done. But half of the times the patient has improved dramatically. And I've been able to make a presumptive diagnosis based on that clinical science and experiment that they are probably having non-convulsive status epilepticus. So I'll leave that up to you about whether you feel brave enough to do that. Any questions about anything so far before we move on to the next section? Okay. So what if it isn't epilepsy? Do you remember that case I gave you right at the beginning? And I said, is there anything else that can be going on? Have you seen patients who are fitting, shaking, having tonic-clonic activity, but who aren't actually having epileptic seizures? Have you seen these patients before? What do you call that? Because I think there's a widespread variety in that in the naming of that condition. Myoclonic activity. I've seen myoclonic activity, of course, in someone with neurological injury. And those are patients, I suppose, who are sitting up talking to you and then demonstrating myoclonus at the same time. What about patients who are non-responsive, in bed, showing all their shaking activity, but they're not having seizures? What is going on? If you were to put an EEG on them, there'd be no epileptic activity there. What is that condition? Have you seen it? I bet you have. Okay. So you've seen it in recreational drug use. Yeah, I suppose so. Either recreational drug use, if someone took a powerful stimulant, could cause either an epileptic seizure itself or can just cause extremely bizarre activity whilst they're intoxicated. Yeah. How about in patients with a history of mental health problems, vulnerable patients, frightened patients, patients with a history of trauma? Malignant hypothermia. So malignant hypothermia, they'd be shaking uncontrollably, all right. I don't know, or they could fit. I wonder if any of you have never seen this then, or heard of non-epileptic seizures or non-epileptic attack disorder. It has a nickname that we often use in healthcare. People call them pseudo seizures. Does that mean anything to anyone? Okay. Non-epileptic attacks. I see, not rarely, I think commonly actually. And I always suspect a non-epileptic attack in a patient who has a prolonged seizure, but they don't have any physiological or hemodynamic instability. For example, they fit, but they never get hypoxic. They don't become profoundly hyper or hypotensive or develop any tachycardia. And also if they just don't respond to benzodiazepines. Yes, so Jay in the chat is saying functional seizures. Yeah, that's why it's interesting to know what you called them, because I think they're called so many different things in so many different places. And even over time, they've changed their names several times since I qualified as a doctor. You go back to the Freudian times, 1920s, they were called hysterical seizures. Then they were called conversion disorder, then dissociative seizures, functional seizures now, or non-epileptic attacks. And the name is important, but the name changes. I'm just interested if you have what you call them wherever you're working. Doctors often call them pseudo seizures. They tend not to hurt themselves. People who have true seizures tend to develop head injuries, broken bones, whereas people who have non-epileptic attacks, functional seizures, tend not to injure each other. And a little thing I would say about them is that calling them pseudo seizures, we know now has not been helpful, because to non-medical people, to lay people, pseudo seizures, the word pseudo means fake. Fake seizures. So when you say to a patient, oh, you have a diagnosis of pseudo seizures, very often patients hear or they understand that they're saying, you've got fake seizures, you're faking it. And they're not. People who suffer from functional seizures or non-epileptic seizures have no control over these episodes. They happen to them and cause them great distress and disability. And they often happen to people with a history of mental health problems as well. So how can we determine, another thing about mentioning names is, are they even seizures? Actually, I'll come to that in a little bit. So how can we tell if someone is in front of us showing all signs of having a seizure, fitting, generalized tonic-clonic? How can we tell if it's a epileptic seizure or a functional seizure? Because they can be really, really similar. And here are common signs which I use and which have shown to be useful in determining whether your patient's having an epileptic or non-epileptic attack. And that's important because you're going to make a decision about whether to give them that stepwise approach, benzodiazepines, anti-epileptics, referring them to intensive care or not. So, number one, the ability of the observer, that's you, to modify the motor activity of the seizure. So if you have a patient who you wonder is having a functional seizure, just coming down to their level, to their ear, and saying to them, my name's Ben Lovell, I'm the doctor looking after you. You're in a safe place, don't worry. Holding their hand and just saying, can you give my hand a little squeeze, just so I know that you can hear me? And sometimes they will squeeze your hand. Sometimes they will suddenly intensify the seizure, thrashing quite violently, and sometimes they calm down. But anyway, if I have managed to change the semiology of the seizure by talking to the patient, then that can't be epilepsy, because people who are having a true generalized tonic-clonic seizure cannot hear or respond to verbal stimulus. Asynchronous limb movements. So that would be, are they alternating their legs, bicycling their legs like this? Epileptic seizures don't look like that. Are they thrashing their head from side to side, left to right like this? Seizures don't look like this. What are their eyes doing? People who are having a true epileptic seizure tend to either have their eyes open or partially open, but glazed over, not looking at anything. If their eyes are screwed up really tight, or they've rolled their eyes back in their head, that's more likely to be a non-epileptic attack, a functional attack. What else we got here? Gradual onset and cessation of seizures. They tend to work up and then slowly wean down. That's a functional seizure. Pelvic movement, such as pelvic thrusting, that tends to be functional seizure. Prolonged seizures without injury or hypoxia or other kind of derangement of the physiology. Resisted eye opening. So if you tried to open their eye and they screwed their eyes up tight against you, that favors functional seizures rather than true seizures. And I've mentioned side-to-side movements. None of these signs of themselves are completely diagnostic of functional seizures, but they're useful information when you're trying to make up your mind. There's a very interesting study here called Can Semiology, the Clinical Signs, Predict Psychogenic Non-Epileptic Seizures? Another name here. There's so many names for them, a prospective study. And they found 6 reliable signs. 3 things which really favor non-epileptic attacks, functional seizures: preserved awareness, so still talking partially to you or responding or crying or screaming, eye fluttering or eye rolling their eyes back, and bystanders, you being able to alleviate or intensify the seizure by talking to them, as I mentioned before. And they found 3 things which more strongly favor epileptic seizures was the abrupt onset, eyes open or eyes even widened but not seeing, and a postictal period. Now, having said that, I've seen people have very profound functional seizures who have a functional postictal phase, and have all of these signs of what's meant to be for true seizures: the abrupt onset, the eyes opening. So it is not easy. The only diagnostic test would be an EEG while they're having the episode, which of course, who has an EEG handy when someone's having a seizure on you? Look at that. So what if you can't tell? It is really tricky. 30 to 40% of epileptic patients also have non-epileptic attacks. So it's not unheard of for someone with epilepsy to have an epileptic seizure and then a non-epileptic seizure, or to have an epileptic seizure and then a few months later have a series of non-epileptic seizures. Calling them non-epileptic attack seizures is a little bit tricky. I've seen people explain to patients using the term seizure, but if you look up the definition of seizure, it actually says abnormal brain electricity, which is not happening in these people. So that's why I keep saying attacks rather than functional seizures. A seizure, by definition, has the abnormality. The average time from a first non-epileptic attack until a diagnosis of non-epileptic attack disorder is over 6 years. And in those 6 years, a lot of patients have come to harm, sometimes by being on long-term anti-epileptic treatments, which has meant they couldn't start a family, or they developed horrible side effects. Some of them have even been to intensive care and been intubated for functional seizures because we struggle to tell. And the reason why it's really important to get the diagnosis right as soon as possible, because we want to protect people with non-epileptic attack disorder from iatrogenic harm, from having all those anti-epileptic drugs, from getting intubated and going to intensive care for organ support and high-level treatments. And actually, the nature of non-epileptic attack disorder is that as soon as the patients get a diagnosis of it and they understand it, they suddenly have a massive reduction in the number of attacks and their presentations to hospital because they have a clearer understanding of what's going on. So it's really important that they get this diagnosis and they understand it in a compassionate, sensitive way. Often I hear neurologists explain to patients that think of the brain like a computer. There is the hardware, the wiring of it, and the software, which is how the programs on the brain work. And they say epileptic seizures is a hardware problem, which we can actually see when we look at the brain, whereas non-epileptic attack is a software problem. The brain is structurally normal, but sometimes the computer just crashes, the software crashes and needs to reboot. And that can be quite a useful analogy for patients to understand what is happening to them. Although, as I said before, saying there are 2 types of seizures, epileptic and non-epileptic, might actually not be the right way to go because, as I say, these aren't actually seizures. They don't have the brain abnormalities. So if someone is in pseudo status epilepticus, but you strongly suspect that this is not epileptic activity. This is a functional seizure. The only thing you can do is wait it out. Speak to your patient who can hear you. Say, don't worry, you're safe. Everything will be okay. And let your team know. Don't let people keep sticking cannulas in them and giving them dose after dose of benzodiazepines because they don't need them. They won't come to injury. Just make sure that they're lying down. They have a pillow under their head, and let them work it out. You can't trick or tease a patient to stop having non-epileptic functional seizures. You can't give them tough love and say, this is ridiculous, stop this, stop all this fuss, this is nonsense, or laughing with other people around the bed space. Oh, ignore them, they're having a functional seizure, they'll get tired soon enough. Doesn't work. In fact, it just makes it go on longer because that's distressing to hear. So it's just being your professional, compassionate selves until they come through it. So I guess all I wanted to say is non-convulsive status is probably an under-recognized cause of prolonged delirium in acute medicine. And I'd just say be sensitive to it. Have a look at your patient who's got maybe an unexplained hypoactive delirium. Have a look at their eyes, have a look at their hands, look for those subtle signs, look for any recent triggers which might cause seizures or any history of epilepsy or structural brain abnormalities that predispose them to seizures. And if you feel brave enough, get an EEG, or if you don't have EEGs, would you consider a trial of anti-epileptics to see if they suddenly resurrect out of their delirium, and maybe it will work. And I would say that epileptic and non-epileptic attacks, they present almost identically actually sometimes, and they present together. So teasing them apart is very difficult, but there are some clues which can lead you to the right diagnosis. And that's the end of the talk. So let me know now in the chat box if any of you have any questions about anything I've said today. I shall wait for a minute or two.